expected. I suspect that her intake was more than we would expect, was the reports of having so many wet nappies in 24 hours. 10 is quite a lot. And also that oversupply of breast milk that mum reported. So we know that breast milk is made on a supply and demand mechanism. So perhaps Maria had been sucking a lot at the breast and stimulating that oversupply in milk production. So what was the practical advice that we gave to the parents? It was to start with 2,500 international units of lipase before each breastfeed. We recommended giving this in apple puree, and if Maria was cluster feeding, or if a feed lasted for more than 30 minutes, we recommended giving an additional half a scoop of Kinder Creon, which is 2,500 international units of lipase at the end of each feed, or at that 30-minute mark, just to ensure better mixing of enzymes with the feed in the stomach. And also offered some support to mum. And one thing that was important to address was just a caution against expressing breast milk as a solution to managing her oversupply, because this will only encourage ongoing milk production to that extent, because it is made on a supply and demand mechanism. I also asked mum to monitor the timing of feeds temporarily and to monitor output, because that is just useful when advising around timing of giving enzymes. So Maria returned a week later, and here are the main findings. Maria had just gained 30 grams of weight in 7 days. A mum reported a definite improvement in her bowel motions. They were seedier than previous and a little bit less frequent. They had some pictures which are really useful and which I'd often request, just to really see what they're like. She was feeding very frequently, up to 15 times a day, and you can see there that her enzyme use was a little bit over the maximum guideline of 10,000 international units per kilo. So we'll now launch our next poll. And the question I'd like you to answer is, you are concerned about inadequate weight gain, and what would you do? You avoid increasing PERT because you've reached the upper limit, or you believe that it's adequate and therefore recommend high calorie formula top-ups to achieve weight gain, or perhaps you would adjust the enzymes based on different characteristics of the breastfeeds and take that risk of exceeding that guideline. So we'll just give you a few more seconds. And perhaps we could see those results now. We're just waiting for those to come in. Okay, so just over half, 53%, would recommend a high calorie formula top up at this point, with the next majority recommending some adjustments to PERT dosing. Okay, so I'll show you what we did. Just bear with me now. Well, I can tell you maybe before the slide moves on that we chose option C, which was to adjust the enzymes based on the characteristic of breastfeeds. And I suppose for those of you who answered around the high calorie formula top-ups, the reason we didn't choose for this option was because mum really had that had a plentiful supply of breast milk. So it was really about getting on top of the enzymes here. My slide is just stuck. Bear with me. Do I still have? Oh, there we are. So apologies for that. Great. So we decided to adjust PERT, as I said. And what this meant in practice was advising to give half a scoop of Kinder Creon before each feed, and where feeds were greater than 15 minutes to give an additional half scoop. So we've changed now from 30 minutes duration to suggesting that change at 15 minutes. And there's no huge amount of science behind that, but I can explain that later. I also, at this point, asked mum to start to tune in to differences in the feeds, and such as how she feels before and after feeds. Does she feel very full at the start of a feed and empty afterwards? How long has the baby slept in between feeds? Because this will give us indication of how large that next feed is likely to be. For example, we can make some assumptions, such as if baby has slept for a long period of time, then likely that next feed baby takes is a larger feed. And also, if mum feels quite full, before the feed and quite empty after the feed, again, likely that the baby has taken a lot of milk from mum. The other situation could be that the baby is cluster feeding, and what that tells us is, although there's quite small, the volumes are likely to be quite small, the duration between feeds is an indicator of, sorry, I should say that the shorter the duration between feeds, the higher the fat content of the breast milk. So that means that is important and relevant because enzymes are dosed depending on the fat. We also commenced fat-soluble vitamin supplementation at this point, although results of her bloods were pending. So Maria returned another week later, and here are main findings. Fecal elastase levels were still outstanding. Her urine sodium to creatinine ratio was low. Vitamin D was slightly low at 45, but she'd had excellent weight gain, so 420 grams of weight gain in the past 7 days. You can see that her enzyme use does exceed that upper limit of 10,000 international units at this point, but I would fully expect that to come down in a reasonably short space of time as Maria gains more weight, because remember that's a guideline based on weight. So my intervention at this point was to reassure mum. I didn't make any changes, but I did provide some education to the parents on the signs and symptoms to look out for that would warrant further changes to their enzymes. And I also started salt supplement at 1 millimole per kilo. So fast forward a few visits and Maria returns again, this time 15 weeks old. And here are our main findings. So at last we have her fecal elastase level results back, and they confirm what we suspected, a diagnosis of pancreatic insufficiency. You'll see there that her growth has been excellent, with all measurements tracking nicely on the centile chart. And her bowels have changed to just one to two a day now at this point, and orange and soft in appearance. She continues to be exclusively breastfed, so we have managed to avoid formula top-ups and see excellent weight gain. And you'll see her enzyme usage as well is back within that upper guideline of 10,000 international units per kilo. So it's really useful, I find, to give the parents some information around how to dose enzymes a little bit more accurately for a breastfed baby, because it can mean that it can actually help to keep within that guideline, because you're not giving too many enzymes for those smaller feeds. And here we have Maria now. She's 26 months old. She has started on her Cambi since 2 years of age, and doesn't she just look the picture of health? And hopefully she has a bright future ahead of her as a result of early intervention. So what are the key learnings from this case study? I just briefly wanted to bring up the evidence, I suppose, for the international guidelines for PERT dosing. So they do recommend that for infants that you start at 2,500 to 5,000 international units of lipase per feed, and that you adjust upwards according to weight gain and bowel symptoms to a maximum of 10,000 international units of lipase per kilo. We should aim for the lowest effective dose, and therefore we usually start at that lower dose at 2,500 international units per feed and increase as we need to. We know that PERT is equally effective taken before, mid or after a feed, and sometimes we do need to divide that up, giving some before, mid and after, depending on the length and the duration of feeds. And there is evidence that that maximum guideline of 10,000 international units of lipase per kilo can be exceeded without harm in the short term. And I'll just show you this quote here from the 2017 New Zealand and Australian nutrition guidelines, which outlined the background to that guideline. So it was based on observations that a mean of 50,000 international units of lipase per kilo per day were associated with fibrosing colonopathy. And therefore it's considered quite a conservative guideline. And to my knowledge, there have been no cases of fibrosing colonopathy in infants reported in the literature. That said, we absolutely still try to stick within that guideline of 10,000 international units of lipase per kilo, and where we need to exceed it, we do so with caution and with close monitoring and follow-up. The second key learning from the case study is that dosing PERT effectively in breastfed infants is challenging, but it can be done. I suppose the challenge is different, contrary to, I suppose, formula-fed babies where you can measure the volumes and you know the fat intake of the infant. We don't know for sure, but there are a lot of indirect measures that we can use, or there are some, I should say, indirect measures that we can use. And those would be looking at the weight gain, the growth on the centile chart, and ensure, hoping to see a nice tracking of centiles, and also the output, looking at the bowel motions. And as I said, pictures can be really useful because parents, you know, one parent's report can be different from another parent's report, and knowing what's normal for a breastfed baby, which is loose and seedy, you know, but it's about the frequency as well. And I suppose just to mention that looking at expressed volumes of breast milk isn't a good indicator of actual intake, because it isn't, it doesn't involve that same hormone release and that same mechanism of breast milk production. And then timing feeds, just I wanted to mention that it's just useful. It's not useful when, I suppose it doesn't tell you much about how much is taken, and that's not the reason for asking for parents to do it. Instead, the reason for asking parents to time feeds is it is useful to know whether we need to split that enzyme dose and give some start, mid and end of the feed. And my final learning, my final message, I suppose, that I'd wanted to bring about, or to highlight today, is how maximizing nutrition support in those early years of life is a preventative strategy. It definitely helps to delay the onset of respiratory disease and leads to better outcomes through growth, lung disease and survival. So I'm going to pass you over now to Jacinta, my colleague here, but I'm going to leave you with just one poll in the meantime as we swap places. All right. Thank you very much.
Okay, so thank you, Jessica, and thank you again to the organisers, and apologies, I know we're running a little bit late. So thank you for that. So 45% of you are using modulators and 55% of you are not. Okay, so thank you for that. Okay, so we'll move on to my case study. Check. Apologies. Did you do it, Jessica? Just took a little bit of time and it just... Okay, perfect. So my first case study is Sarah. So she's a 14-year-old girl with CF, and the medical and social history is, I'm going to start from 2016. So Sarah was diagnosed at birth with Delta F508, and in 2016 she presented with some abdominal pain impacting on her growth. Social history, she lives with family, they're very supportive. She has an older sister who also has CF, and she's very active. She swims a couple of hours a week, and she also plays soccer. In terms of nutritional medication, she's on fat-soluble vitamins, Creon, and PPI as well. Okay, so I'm just going to show you her growth chart here, and so you can see where, let me see. So this is where we picked up Sarah in at 2016. So she's had a little bit of a growth faltering there from the 97th down to the 90th centile. Okay, and when we done a nutritional assessment looking at a 3-day food intake record, we can see that her intake was excellent. She was well exceeding her estimated nutritional requirements for energy, protein, calcium and iron. However, we did notice some discrepancies with creatine fat ratio in the diet, and also her all of her vitamins were completely in range, and her iron levels and ferritin as well. So another poll for you. So what would you do at this stage? So you can see that her intake is very good, no obvious deficiencies. So would you just continue to monitor? Would you offer nutritional supplements? What about explore the use of Creon? Or would you refer to gastroenterology to investigate the abdominal pain that is relatively new at this stage? Okay. And we'll see results when they come in. Okay, so 57, the majority of you said you would explore the use of Creon, and a minority would just continue to observe. Okay, well, we actually done a combination of all of those. So we did explore the use of the use of Creon, and we found that we tried to, there is no specific guidance on how much Creon exactly you would take. Jessica already mentioned the kind of the upper limits that you might look for, but we suggested going with 1 Creon per 1 Creon, 10,000 international units of lipase per 5 grams of fat. We also started and suggested a supplement that she could try, and she took to this very well, and there was good compliance with this supplement. There was good compliance with the supplement, and sorry, I'm just getting my slides to move on. And good compliance with this supplement. It was a milkshake drink, and it provided an extra 600 calories and 12 grams of protein. And we did refer to a gastroenterologist, and they diagnosed non-organic symptoms and suggested psychological support. And we, of course, advised on high protein, high calorie foods and fortifying diet with some extra snacks. Okay, so moving on, then in 2017, she'd continued to still lose weight, and we can see a further drop on the centiles. So she dropped a centile and a half now by this stage, and she's so she's the 75th to the 90th centile there. So would you consider a PEG for Sarah at this stage? Yes or no? Would you consider a PEG? So we'll see the results there. So 57%. So it's really quite close in terms of who would or would not consider a PEG. So 57% would consider a PEG. And actually that was certainly what we did consider at that stage. So there is a lot of evidence for the benefits of enteral tube feeding. So a lot of evidence to show that enteral tube feeding can increase total energy intake. And this is reflected in increases in body weight gain and BMI, height and height velocity. We know it can change body composition with an increase in lean muscle mass. There can be a reduction in respiratory function and an improvement in lung function, fewer hospital admissions and infections, and improvement in physical activity. A Cochrane review in 2019, there is no well-designed randomized controlled trials looking at enteral tube feedings, and there would be an ethical issue around whether that could be undertaken or not. Of course, there's challenges with tube feeding as well, and we're all very familiar with some of these in terms of transient nausea, vomiting, some reflux, abdominal pain, loose stools. With NG feeding, which is very much a short-term measure, there can be nasopharyngeal irritation, and also complications in terms of the PEG site, infection, overgranulation, and really importantly, a self-conscious and poor body image of many patients is reported in the literature, and this is really important to consider. So we did consider a PEG, and we introduced the idea of a PEG at this stage. It wasn't something we done immediately, but we introduced it, and it was important to do that at the time, and really important to also explore with the family around when a PEG might be introduced, that it's not seen as something negative. It's not a failure of nutrition that a PEG might need to be introduced, and we very much relied on the full MDT in terms of support, but particularly our psychology team members for supporting the family during this time. So moving on to 2018, Sarah continued to deteriorate, and her lung function our FEV1 was 36%. Oral glucose tolerance test was completed and it was normal, and she was having regular IV antibiotics during this time. From a nutritional point of view, her appetite continued to decrease, and we continued with food fortification, adding in extra supplements. Weight was relatively stable, and significantly in 2018 we started our CAMBI. So what we can see here is by September in 2018, she'd further lost, deteriorated on the growth centiles, and she's just above the 50th centile. So, you know, from when we first introduced her with the arrow, you can see that, you know, in that year, she'd further dropped another centiles. She was really struggling with meals, only taking about 75%, and taste fatigue, which is so common with a lot of supplements, she had just gone off of the supplements. So we placed a peg, and as per kind of the ESPN guidance, we started off with a standard enteral tube feed, and we were feeding overnight per patient preference, with giving enzymes at the start and at the end. In 2019, Sarah continued to deteriorate. We started Symkevi, Kalydeco, but by June in 2019, her FEV1 was 31%, and the medical team began discussion around transplant. Sarah was receiving regular IV antibiotics at this stage, and the full MDT was involved in care. The peg was converted to the Mikey button, and we really found that her appetite had really decreased for food. So the peg feed, you know, it was very much a support for nutritional intake, but by this stage in 2019, her appetite for meals and foods, and there was a lot of discussion around kind of pressure to eat and stress associated with meals. So that so we ended up increasing her peg feeds, and we can see our weight was relatively stable there in the 50th to 75th centile. In 2019, we got a body composition BIA machine, and we completed this on Sarah. So what I'll draw your attention to is, you can see there the two middle lines on this slide show the weight and the BMI, and they were falling completely in the healthy range. But what is really significant is a really low muscle mass and a really high fat mass that we could see in Sarah that was not obvious by looking purely at weight and BMI. So we know that there's a lot of challenges with BMI. We know that it can cause stunting, and we would never look at BMI independently of growth charts. But that is one of the challenges, that that BMI doesn't differentiate between fat mass and fat-free mass. And this is important because there's a lot of research now showing that increases in fat mass and in the presence of a normal BMI, which is called, the term they're using is normal weight obesity, is inversely associated with poor lung function. And BIA machines looking at body composition have been validated with a specific CF equation. And I suppose our disclosure is that we have not been using the CF equation. We're working with the BIA manufacturers to try and see what way that equation might work with the machine that we have. But ESPN is certainly acknowledging that, you know, as we begin to move, so back from the days in terms of the Toronto and Boston study where we looked at survival with BMI, improvements in BMI, now there seems to be an appreciation that BMI is somehow a proxy for lean muscle mass, and the lean muscle mass is what's important. So moving on to 2020, in March, Sarah started in Kaftrio, and prior to starting on that, she'd been on BiPAP and home oxygen, and FEV was holding around 34%. But 6 months on Kaftrio, there was a dramatic improvement, and her FEV1 was 49% in October 20. There was a dramatic impact on nutritional intake. She suddenly had a huge appetite for meals and snacks, and really importantly, found the love for food again. We were able to reduce peg feeds by 50% in the first month, and stopped it completely 2 months after starting on Kaftrio, and we've removed the peg completely in October 20. And weight, she's managed to kind of hold her weight, and we've repeated her body composition analysis. We've repeated body composition analysis again, and what I will draw your attention to here is, again, weight and BMI you can see completely in falling within the normal ranges, but really positively what we can see is on these two screens here, where the two arrows are, is looking at fat muscle mass and fat mass. So the lean muscle mass has dramatically increased, and the fat muscle mass has reduced. The fat mass, has reduced with the commencement of Kaftrio, which has been really positive. So it certainly is really important to think about body composition in our patients, and particularly as we begin to move towards using some of the modulators, because the impact certainly in this case was quite dramatic. The final study case, and it's not so long, I'll run through, is with Aisling. Aisling's a 16-year-old girl with CF. She was diagnosed at 4 years of age. Her genetics was delta F508, G551D, and she's pancreatic insufficient. She's an older sister, who doesn't have CF, and she was on IV catheter, started in 2013, and taking fat-soluble vitamins and Creon. There was an acute weight drop, and I'll show you her growth chart in a minute, when she was 16 years of age from the previous 6 months. She wasn't reporting any impact with bowels, but I certainly would question that, because there was a lot of poor compliance, and she was forgetting to take Creon in home, and it certainly wasn't consistent Creon usage at home as well. And her oral intake had reduced, and from nutritional assessment, she was only managing about 68% of requirements. Her oral glucose tolerance test had been indeterminate in 2014, 15, and 16, and she was diagnosed CFRD in 2017 and commenced on Levemir. So this is the weight drop there that you can see. So she went from just below the or just above the 10th centile to way below the 3rd centile. And I've put the second hour in there just to flag that this was when she was diagnosed with CFRD, and so we can kind of see she gradually was deteriorating for a little while. So CFRD, it's a distinct form of diabetes. It's most common comorbidity associated with CF with high percentages, and it does impact on life expectancy. And there is evidence that starting insulin helps to improve respiratory and nutritional health, and to reduce some of the complications. And really the importance, which we do here in Tala, is of linking in with endocrinology and CF MDT in managing. So this is the last poll I had, and I just wanted to check, do you routinely check oral glucose tolerance tests in children less than 10 years of age? So yes or no? So 70% of you don't routinely check oral glucose tolerance tests in children less than 10 years of age. Okay, so very interesting. So the oral glucose tolerance test, the recommendation is that it would be done from 10 years of age in all CF patients who don't have diabetes. But however, we do it from 6 years of age, and we do it every alternative year unless abnormal. And 2 abnormal oral glucose tolerance tests we'll send for CGMS. Currently, 4 of our 7 patients who have CFRD would have been diagnosed under 10 years of age, and 10 of our indeterminate oral glucose tolerance tests out of 24 are currently under 10 years of age. So we are seeing quite a lot of those under 10s with abnormal oral glucose tolerance tests. And This is a little bit just repetitive, but it's the ISPAD guidelines on managing CFRD, and just the importance of that. The sugars, the diabetes targets can be very much individualized, and that perhaps diet might not be so strict. For Ashleen, you recall she was on 2 units of Levemir, so that was changed. She was hospitalized when we seen her at 16 years of age with that acute weight loss. She got IV antibiotics. We started her on insulin, and she is really, so she went on to Lantus and MDI with regular insulin injections, and there was a lot of education went into carbohydrate counting in terms of how to manage it, all within the context of CF, all within the context of CF. So generally we would be a little bit more liberal within the diet, and just also the importance of calcium and bone health, which is an increased risk, particularly with CFRD. So the outcome, just to show you her growth chart, a dramatic improvement again with the introduction of insulin, which was desperately needed. And also there was also a really good turnaround in terms of this young girl, you know, has taken on the responsibility. There was a lot of patient empowerment and self-management of her diabetes and her CF since this particular episode. So just to acknowledge and finish up, and I'm so sorry we ran over in terms of time, and thank you for bearing with us, and apologies for the technical difficulties, and just to acknowledge very much that we work within a really strong CF team, and to acknowledge our patients as well. So thank you. And we can have a look and see if there's any questions. If anybody has any questions that you would like to send through, we have maybe a minute or two to answer some questions. So I don't think we're getting any questions. So thank you. There's one here. In view of increasing concern, increasing fat mass due to high calorie diets, what would be your recommended weight, BMI centile? Thank you. Really good question. So what I would say is it is important to, particularly as we move to some of the modulators, so we don't necessarily encourage particularly high fat diets. They can play a role when we have concerns around kind of weight loss. If you have body composition machines, use them, but if you don't, I would suggest that you use weight, and BMI is all that we've got if you don't have the measures. But it's also worth looking at other measures like maybe hand grip strength as a proxy measure for muscle strength as well, and that would be worth looking at, and just keeping an eye on weight if you see that it is beginning to increase. Jessica, do you want, when do we need to prescribe, another question, when do we need to prescribe high calorie formula for CF infants?
Thank you for that question. I think it's very much a case-by-case situation. I think if we had concerns, you know, where if over a longer period of time that the baby didn't thrive, and you felt that enzymes were maxed out, you know, then it might be worth considering at that point. But in that particular case study that I presented, only a week had passed. The baby was still very young at 4 or 5 weeks of age, and it really does take more time to establish breastfeeding. The guidelines that we use here for the general population, they're not CF specific, but it's that a baby regains their birth weight by 3 weeks of age. So the case study I presented had not only regained her birth weight, but had actually above that gained 420 grams in that first week. So, you know, she was in a good place, you know, in a reasonably good place nutritionally. And it was more around starting the enzymes in that case. But it would be if the baby has really dropped on their centiles and with a little bit more time isn't managing to catch up. That's when I would consider the formula top up. Or if there were concerns around mum's supply. But usually I find there's a breastfeeding solution to a breastfeeding problem.
Very good, excellent. We have loads of questions, but unfortunately we won't have time to answer them. And again, we apologize about the little technological glitch. And we'd like to thank our speakers. And I'm sure you'd all agree with me that this was a very informative session. Jessica, quick question, picture of stools. This is very helpful. So would you recommend the parents to have picture of stools at the beginning and after enzymes, or how often?
Yeah, absolutely. Yeah, very good question. I would recommend that the parents often do come in with pictures, and I would say I would encourage them to just send me some by email if they have any concerns. You know, I might show them a picture of a normal nappy, so that they can see what's normal, and then they frequently send me as pictures if something is different from their baby's norm. And
it's always difficult giving enzymes to a breastfeeding baby. Apple puree, any other alternatives?
Yeah, you can give the enzymes in a little bit of express breast milk, actually. But from my experience in doing that, the mums would report it's a little bit trickier for the baby to take it because it's such a liquid consistency. But if you really want to support exclusive breastfeeding, then I guess that is, you know, that would be a good first action to take, that they give it in a little bit of express breast milk from a spoon, and then let the baby latch directly to mum at that point.
Excellent. And Jessica, what are your guidelines for starting PEG feeds or parenteral gastrostomy tube feeds? Yeah, Jacinta, sorry.
Yeah, so we would very much look at kind of the ESPEN guidance in terms of keeping an eye on weights, and also in terms of kind of growth faltering guidance in terms of when we can see the drops off in the centiles. But a lot of the time is very much about working with the families and looking at a lot of the other clinical parameters as well.
Very good. When do we need to prescribe high caloric formula for CF infants? Question.
I guess it would be two situations. If it's a formula-fed baby who isn't thriving, and you feel that there's no there isn't ongoing malabsorption, the enzymes, the parents have a handle on the enzymes, and you feel that is dosed correctly, then I suppose you could, at that point you would possibly consider a high-calorie formula. I find it is quite rare, because remember that certainly in our cohort of patients, these babies are very well, at birth from a lung perspective, so they don't tend to have higher requirements. And I would always allow them a little bit of time. But if we felt that they were growth faltering, the definition for that would be their weight dropping 2 or more centiles below their length centile. You're really just concerned that they weren't gaining weight over a period of time, you could consider that.
Excellent. And I'm conscious Masooma is with us. Masooma, any word of wisdom as somebody practicing CF dietetics in the Middle East? Any challenges?
Diabetic patient?
Generally, any issues?
Yeah, as I talk in my presentation, the main problem with the diabetes patient that how the parents can manage the insulin and the cryon together. This is a big challenge for them. We have a lot of the patients that if they with the diabetes, parents, they will be panic how we can manage the two things, which is it is important, and it is difficult to make the children to control the carbohydrate and the fat together, or to increase the fat and the control the carb intake. This is the big challenge that we're facing, Dr. Bassel.
And surely this is obviously something probably we need another webinar to talk about. Listen, I'm conscious of the fact that we've gone over time, and the registration for the next workshop is separate, so please go ahead and register for the next workshop. And then I would like to extend my sincere thanks to Masooma, Jessica, and Jacinta. It has been an excellent, informative webinar. We apologize again about the little glitch, but I think what you guys have given us today is a lot of food for thoughts, things that we can do and develop within our units globally. Thank you all, and I'd like to thank you, the audience, for your interaction with the speakers. And this will conclude this workshop. And as I said, in 15 minutes, the next workshop will be starting with Professor Peter Mugazel and dealing with common and uncommon respiratory infections. Thank you. Thank you.